Hey guys, it's Medicosis Perfringens, where medicine makes perfect sense. Let's continue our microbiology and infectious diseases playlist. In previous videos, we talked about Clostridium tetani, Clostridium botulinum, Clostridium perfringens, and Clostridium difficile, as well as other less famous Clostridia. Today, we'll have a very quick review on all of these topics. If you haven't watched the previous videos in this playlist, there is no hope for you understanding anything today because it's a very quick review. Let's go. Clostridia are gram-positive cocci or bacilli. They are bacilli. They are gram-positive rods or bacilli. Are they spore-forming? Yes, indeed. Aerobic or anaerobic? They are anaerobic. Motile or immotile? Mostly motile, with the famous exception of Clostridium perfringens. What family can we put them in? The Bacilliaceae family. Clostridium tetani causes tetanus by inhibiting the GABA, which is inhibitory neurotransmitter. When I inhibit the inhibitory, I become excitatory, meaning spastic paralysis. Next, Clostridium botulinum, which causes botulism. By inhibiting the release of acetylcholine, there is no muscle contraction anymore, I'll get flaccid paralysis. Next, Clostridium difficile with its famous two toxins. Toxin A is enterotoxin, toxin B, or number 2, is cytotoxin. Diseases include self-limiting watery diarrhea and gastroenteritis, and severe pseudomembranous colitis, and the more severe, toxic megacolon. Just like my past relationship. It was toxic and full of poop. So toxic to the point that I developed altered mental status, hypotension, fever, and very high leukocytosis, to the point I landed in the ICU. What I've just said about my past relationship is not true. What I said about C. difficile is savage. As for Clostridium perfringens, it's the classic story of these two soldiers who were fighting. One of them got injured and punctured with a sword. He fell onto the soil. His open wound got contaminated with the soil. What does the soil have? Clostridia, including Clostridium perfringens. Boom! We're talking myositis, fasciitis, myonecrosis, gas gangrene, you name it. Clostridia can make spores, yes, for the most part. Recall that only some gram-positive bacteria can make spores, but gram-negatives never make spores. Structurally speaking, the spore is full of calcium. We have calcium dipiclonic acid. Function-wise, the spore protects the bacteria from unfavorable conditions. The classic definition of Clostridia is here. Gram-positive bacteria, strictly anaerobic, they can make spores, but they cannot reduce sulfate to sulfides. Is this a perfect definition? No, it's not, for these reasons. Why are these nasty Clostridia such a big deal? Because they are everywhere around us, because they are part of your flora, because they can make spores, they can produce toxins, and they can grow even when there is no oxygen. Hashtag anaerobic. Please pause and review. Number 1, Clostridium tetani, which causes tetanus. Look at that tetanospasmin causing spastic paralysis. Why does Clostridium tetani cause spastic paralysis? Because it inhibits the release of the inhibitory neurotransmitter. Inhibition of inhibition is excitation. Hashtag spasticity. Name the toxin, tetanospasmin. Contrast that with Clostridium botulinum, which decreases the release of acetylcholine, causing flaccid paralysis with no muscle contraction. My muscles are very stiff versus my muscles are very lax. Because I inhibited the release of the inhibitory neurotransmitter. Because I inhibited the release of the contracting neurotransmitter, i.e. the neurotransmitter that causes muscle contraction. Clostridium tetani, tell me about yourself. I am everywhere around you. I'm strictly anaerobic, that's why I'm very hard and difficult to culture. My spores look like a drumstick. If this is not the best name for a restaurant, I don't know what is. This joke is getting old. Clostridium tetani produces two famous toxins. Oxygen-labile hemolysin, known as tetanolysin, and heat-labile neurotoxin, which is the famous tetanospasmin. A classic exotoxin, i.e. A-B toxin. We have an A subunit and a B subunit. The A subunit is active. It has the enzymatic activity, the catalytic activity. What enzyme are you talking about? Zinc endopeptidase, which is a zinc metalloprotease. How about the B subunit? B is just for binding with your your cell receptor. Pardon me. Pathophysiology of tetanospasmin. It's a classic exotoxin, AB toxin. The B subunit is for binding, of course, especially the C terminus, which is the carboxyl terminus. It will bind your sialic acid receptors and your glycoproteins in your neurons, usually your axon. And then it will be engulfed inside your axon, thank you endosome, and then by retrograde axonal transport, it will reach the soma, which is the cell body of your neuron. Thanks to your metabolism, which secretes acids by the way, you will acidify the endosome. When the endosome is acidified, a conformational change will happen. And now the A chain will come to play. A for active, A for enzyme activity, zinc metalloprotease, namely zinc endopeptidase. Protease peptidase is an enzyme that breaks down proteins and peptides, such as your snare proteins, which are responsible for the release of neurotransmitters. When I inhibit your snare, you will be unable to release GABA. When you cannot release the inhibitory neurotransmitter, you will be excitatory, hashtag spasticity, hashtag trismus or lockjaw, hashtag opisthotonus or hyperarching and hyperextension of the back, and hashtag rhizus sardonicus or the classic sardonic smile with facial muscle spasms. Buyer beware, the binding of tetanospasmin to your neuron is irreversible. Hey, Medicosis, will I recover? Only if you can regenerate and repair and make new terminal axon knobs. Only then is there a hope for you to recover, which if happens takes months and months and months. Tetanus inhibits GABA release, causing spastic paralysis, versus botulism, which inhibits acetylcholine release, causing descending flaccid paralysis. Do not confuse the descending flaccid paralysis of botulism with the ascending flaccid paralysis of Guillain-Barré, which can be triggered by another bacteria known as Campylobacter jejuni or a freaking virus known as Zika virus. These are not the only triggers, not by any stretch of the imagination. These three wonderful diseases can kill you from diaphragmatic paralysis. How many types of tetanus do we have? We have many. We have localized tetanus, we have cephalic tetanus, which is rapidly fatal because it starts in the brain, and we have the famous, most common, generalized tetanus, where the motor symptoms, hashtag spasticity, and autonomic symptoms, hashtag sweating, fluctuating blood pressure, and volume depletion. And there is a famous subtype known as neonatal tetanus, the classic archaic story of cutting the umbilical cord with a kitchen knife, or with an axe, or with anything contaminated with water, or with the soil, rich in Clostridia, because it's ubiquitous. Clostridia are everywhere around us. After watching this video, if you ever make this mistake, you should be buried under the prison, because the mortality rate is greater than 90%. What the flip are you doing? How can we diagnose tetanus clinically and culture? The culture is very difficult because as soon as Clostridium tetani smells one molecule of oxygen, it's not going to grow and it's going to ruin your test. This is how you find the bacteria with its classic drumstick spore. How can I find the toxin known as tetanospasmin? You need to neutralize it with an antitoxin. When the toxin binds the antitoxin, when you confirm the binding, you have confirmed the presence of the toxin. What do we call it when the toxin and the antitoxin hug each other? Neutralization test. Just like how an antigen and an antibody neutralize each other, we call it agglutination in that case. Because prevention is better than cure. How can I prevent tetanus? Vaccine and the booster every 10 years. Treatment, surgical debridement of the first primary wound. Even if the wound looks fine and innocent to you, you still need to debride it. We're talking tetanus here, it's no joke. Antibiotics like penicillin and metronidazole will get rid of the bacteria. And when you kill the bacteria will stop making new toxin. But hey, Medicosis, how about the toxin that was already formed? You need to neutralize it. Passive immunization via human tetanus immunoglobulin, which will bind the already formed, the already produced toxin. Better catch it early, because once it binds to your neurons, it's not going back. This was the passive immunization. Then we have active immunization, which is the tetanus toxoid. A toxoid is not the same as toxin. Oid means like. Similarly, android is not the same as andro. Android means man-like the famous robot of Google. But andro means a man, a human. Cancer is different from carcinoid. Leukemia is not the same as leukemoid reaction. We're done with Clostridium tetani. Let's talk about Clostridium botulinum. By inhibiting the release of acetylcholine, you'll have flaccid paralysis. Hypotonia, not hypertonia. Clostridium botulinum is everywhere around you. Spore-forming, yes indeed. Anaerobic, true. Heat labile neurotoxin known as botulinum neurotoxin or botulinum toxin, another exotoxin, i.e. A-B toxin. The B is for binding with your receptors. The A has the enzyme activity. Here is a lovely comparison between two ugly toxins, tetanus toxin and botulinum toxin. We have talked about this in previous videos, so please pause and review. If you ever want to download these handwritten notes, please check my website, Medicosis.com. Botulinum toxin. How many subtypes do we have? We have 7. A, B, C, D, E, F, and guess what? G. Many scientists argue that botulinum neurotoxin is the most potent toxin to humans on the face of the planet. Even a few nanograms can kill you. The good news is the doofus is heat labile. When in doubt, cook it out. If you think your tuna can has been polluted and compromised via botulinum toxin, just cook the tuna for 10 minutes or so, and you will kill and destroy and inactivate the most potent toxin on the planet. Isn't that cool? Organized knowledge is power if you understand what the flip you're talking about. How does botulinum toxin work? By inhibiting the release of acetylcholine, giving you flaccid paralysis. I mean ptosis, diplopia, constipation, descending flaccid paralysis, floppy baby syndrome, etc. Also by breaking down your snare protein, namely SNAP25 protein, which is responsible for the release of acetylcholine. How many types of botulism do we have? We have 4 types of this disease: foodborne botulism, infant botulism, wound botulism, and inhalation botulism. Foodborne botulism, we're talking about the compromised tuna can, or any aged seafood or cured fish. We're talking homemade canned food, homemade carrot juice that was not properly refrigerated, giving enough time and an opportunity for the spores to form. Incubation period 1 to 3 days from the day of consumption. Clinical picture is related to decreased release of acetylcholine. We're talking blurry vision, double vision, droopy eyelids, dry mouth, descending flaccid paralysis, constipation, fixed dilated pupils because they cannot constrict because there is no acetylcholine, dysarthria, dysphagia. I cannot talk. I cannot swallow. Why not? Because there is no acetylcholine there. Notice all of these symptoms were purely motor. Your sensations are fine in botulism. How can we diagnose it? Try to find the toxin in the serum. How can we treat it? Give me an antitoxin. Also, get rid of this nasty food. Bowel emptying via gastric lavage. Antibiotics might help because they kill the bacteria and prevent the formation of new toxin. How about the already formed toxin? You have the antitoxin for that. Number 2, infant botulism, the floppy baby syndrome. We're talking about spores from honey or soil or dust that has been ingested. Then they germinate and produce toxin in the gut of the baby. The symptoms are also related to decreased acetylcholine release. You diagnose this disease clinically, you confirm it by finding the toxin or the spores of Clostridium botulinum in the stool. Treatment is intravenous human-derived botulism immunoglobulin. Here is a comparison between foodborne botulism and infant botulism. Pause and review. Number 3 is wound botulism. I got an open wound contaminated with Clostridium botulinum. Before you know it, there is botulinum neurotoxin in my body. and before you know it, there is no acetylcholine release. Treatment, it's a toxin, give me the antitoxin. It's a wound, surgical debridement. Fourth, inhalation botulism, very rare, almost unknown to medical students and to most physicians. But the danger is always lurking in the background. It can happen. How can we diagnose botulism? Culture the bacteria and try to identify the toxin. How can we treat it? Beware of diaphragmatic or respiratory paralysis, because ABCs come before anything else. Maintain the airway, baby. Neutralize the toxin by an antitoxin. Get rid of the bacteria by gastric lavage or antibiotic. Antitoxin is against the toxin. Antibiotic is against bio, the living organisms, i.e. bacteria. What kind of antibiotics? Just like tetanus, baby. Metronidazole or penicillin. Surgical debridement for wound botulism. Prophylaxis, proper refrigeration, and when in doubt, cook it out to destroy the toxin. You cannot practically destroy the spore. You're not a microbiology lab, just be humble. Personally, you cannot destroy the spore. Can you destroy and inactivate the toxin? Yes, you can. When in doubt, cook it out. And here's a comparison between these three types of botulism. Pause and review. Number 3, Clostridium perfringens. Remember perfume. Yes, my patient is about to die from gas gangrene and my necrosis, but at least he smells really good. Smells nauseatingly sweet like decomposing apples. The best smelling patient in the entire hospital. Meanwhile, some patients with heavy metal poisoning smell like two dead fish having sex together. But doctors will not tell you this to your face. They're trying to be professional. Oh, by the way, I have a video on my channel titled Abnormal Body Odors. Diseases caused by Clostridium perfringens include fasciitis, myositis, myonecrosis, gas gangrene, gastroenteritis, etc. Toxins include the alpha toxin, the beta toxin, epsilon toxin, iota toxin, and the enterotoxin, which causes gastroenteritis. So how did I get my necrosis? Alpha toxin. How did I get gastroenteritis? Enterotoxin. This is the story of myositis, myonecrosis, and gas gangrene caused by Clostridium perfringens. The disease is rapidly fatal. Please pause and review. This is the watery diarrhea or the food poisoning caused by Clostridium perfringens. Please pause and review. There is a severe form of Clostridium perfringens known as necrotizing enteritis. Please pause and review. This one is caused by the beta toxin. How can I diagnose Clostridium perfringens? It's a gram-positive rod with the absence of leukocytes, anaerobic medium to culture it, and try to detect the toxin in the stool sample. Treatment of myonecrosis is surgical debridement, very high dose penicillin, hyperbaric oxygen chamber may or may not work. Anti-serum against alpha toxin has been discredited. Food poisoning, self-limiting. You do nothing, just support the patient until the gut flora reestablishes itself. Fourth and last, Clostridium difficile. Toxin A is enterotoxin, toxin B is cytotoxin. Toxin A damages the brush border, toxin B damages the cytoskeleton of your gut. I'm talking small and large intestines. Some people are asymptomatic, some people have self-limiting diarrhea, some people have pseudomembranous colitis, toxic megacolon, and succumb to their illness. Any antibiotic can trigger an attack of pseudomembranous colitis, especially clindamycin, tetracycline, aminopenicillins, aztreonam, and cephalosporins. Why do antibiotics do this? Because they alter your normal intestinal flora, making you vulnerable to overgrowth of endogenous C. diff or acquisition of exogenous C. diff. How can we manage pseudomembranous colitis? Other antibiotics, such as the 3 modes of transportation. You can take the Metro, the van, or the FedEx truck. Metronidazole, vancomycin, fidaxomicin. Toxic megacolon is a complication of pseudomembranous colitis. Please pause and review. How can we diagnose C. diff? Forget the bacteria. We're not trying to find the bacteria. We're trying to find the toxin in your stool. What toxins? Toxin A is enterotoxin, toxin B is cytotoxin. What if I just found the bacteria? This has proven colonization. This does not prove the disease. In order for you to prove the disease, you need the clinical picture, the medical history, and you need to establish the presence of the toxins of C. diff in the stool. The best way to do this is to find the genes that code for the proteins, that code for the toxins. How do I find these genes? In the stool of the patients via PCR or any nucleic acid amplification technique. Treatment: the metro, the van, and the fidaxomicin. Metronidazole is given orally in mild to moderate cases, is given intravenously in severe cases. As for fidaxomicin, it's an oral medication. As for vancomycin, always oral. Yes, vancomycin is available intravenously, but please never ever give IV vancomycin to treat pseudomembranous colitis. Because if you give intravenous vancomycin, it will go to the blood and it will not reach a sufficient minimum therapeutic concentration in the gut sufficient to treat the pseudomembranous colitis. If you want to treat pseudomembranous colitis, give me oral vancomycin, because oral vancomycin will go to my mouth, esophagus, stomach, intestine, stay in the intestine, achieve a sufficient minimum therapeutic concentration, which is important to punch the Clostridium difficile in the guts. No pun intended. What if the case is severe? You give me the intravenous metro and the oral vanco together. Still not working? Try the fecal microbiota transplant, the poop shake. Does anyone remember several years ago when it was trendy to throw a milkshake in the face of politicians and celebrities that you did not like? Politicians should be grateful that the angry person was not a gastroenterologist at the NHS, because he would have thrown a different kind of shake. And just in case there is some lawyer watching, Medicosis does not condone any act of violence. We do not endorse any reprehensible behavior that breaks apart the fabric of society, just like how Clostridium botulinum neurotoxin broke apart the snare protein, inhibiting the release of acetylcholine, giving you flaccid paralysis, making you unable to throw a milkshake in the face. Shut up, Medicosis. Other less famous Clostridia include Clostridium septicum, which can lead to atraumatic myonecrosis and rapid death, especially if you had colon cancer, diabetes, or leukemia. We have Clostridium sordelii, which leads to toxic shock syndrome, hagma hemoconcentration, no fever, yet there is abscess, hemorrhage, necrosis, and rapid death after childbirth or medically induced abortion. And Clostridium tertium, very similar to Clostridium perfringens, again, myonecrosis, gas gangrene when your wound got contaminated with the soil. Let's review the treatment of Clostridium difficile colitis from Picmonic. Remember the modes of transportation. The metro is metronidazole, the van, vancomycin, and the FedEx truck, fidaxomicin. Also, do not forget the poop shake, fecal microbiota transplant. If you like this video, you will enjoy my antibiotics course, which will teach you about antibacterials, antivirals, antifungals, and antiparasitic medications. You can download it today at medicosisperfectionalis.com. I also have a general pharmacology course to learn about pharmacokinetics and pharmacodynamics and all sorts of equations, an endocrine pharmacology course, and my beloved acid-base imbalance course, the best on the planet. Thank you for watching. Please subscribe, hit the bell, and click on the join button. You can support me here or here. Go to my website to download my courses. Be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine makes perfect sense.